Many of you have perhaps heard Dr. Dodson, who is just an extraordinary font of information for Attitudes readers. He is a board-certified psychiatrist. He's been working with adults with ADHD for over 30 years. A former faculty member at Georgetown University and the University of Colorado Health Sciences Center. He's currently in private practice in Denver, Colorado, where he is a life fellow of the American Psychiatric Association, and he's a member, fortunately for us, of Attitudes Medical Advisory Board. So, Dr. Dodson, thank you so much, as always, for joining us today.
Thanks, Susan. As Susan said, ADHD as a topic is generally ignored in medical education. The last time anybody looked, which was about 5 years ago, 93% of adult psychiatry residencies didn't mention ADHD in 4 years of training, and amazingly, half of pediatric residencies did not mention ADHD. So if you have a physician who has taken the personal time to get up to speed with ADHD and how to use the medications, you have found a real gem. If you haven't, then you need to probably find out from your own neighborhood who is good and who isn't. Probably the best way to do that is either to go on to the referral section of Attitude magazine or go to a CHAD meeting, children and adults with ADD. These are people who were in your shoes just a year ago, and they can give you a great deal of very practical guidance. We're going to talk about how to use the first line so-called stimulant medications. You need to know that this information comes from somewhere. It comes from the practice parameter update from the American Academy of Child and Adolescent Psychiatry. It was done in 2007, so a new one it should come along pretty soon. You can get it on the web. It's in the public domain at www.aacap.org. And you'll see on the left-hand side of the screen practice parameters, and all of the practice parameters are there for you to look at. One of the biggest changes that they made in this practice parameter update was the acknowledgement that only medication has been able to show detectable lasting benefit. If you look on page 903, there's a review of 82 studies in a row that did not use medication, and none of them were able to demonstrate detectable lasting benefits for the core symptoms of ADHD. Now, let me put in a caveat immediately. I'm not saying that these therapies don't help or coaching isn't incredibly valuable. What it says is that for the core symptoms of ADHD, inattention, distractibility, impulsivity, and hyperarousal, none of the behavioral management techniques, diets, megavitamins, anything like that, has ever been able to show any benefit at all. And that results in recommendation number 10, which traditionally had been called the multimodal treatment recommendation. And now what recommendation 10 says is if you get a good response to medication, that's it. You don't have to do anything else. So basic concept number 1 is medications are the treatment of choice for ADHD, not as they've been traditionally looked at as the treatment of last resort when a person has tried literally everything else they can think of. The only exceptions to that are somebody who is in either very recent or unstable substance abuse, someone with uncontrolled glaucoma, which is increased pressure in the eye, uncontrolled seizures, untreated cardiovascular disease, and also one that probably should be in there for the psychiatrist is untreated, unmanaged bipolar disorder. Now, the thing to remember is that when you do get all of these conditions under good medical control, then the stimulants once again become the treatment of choice. There are 29 FDA-approved first-line stimulant formulations for the treatment of ADHD. But all 29 are just different ways of delivering only two molecules, methylphenidate and amphetamine. There is no evidence anywhere to indicate that one molecule is intrinsically better than the other. Here you need to be introduced to a concept called effect size. As you might imagine, when a physician is working with any patient, they want to make sure that they are matching up the very best treatment possible with that unique individual. And one of the things that best informs that whole decision-making process is a statistical calculation called effect size. And it allows us to compare clinical experience, research done at different times, different places, but it sort of mashes it all together, and you end up with a ratio. How well does this particular treatment work as compared to all the others we might have tried? Just about everything in medicine comes in between 0.4, which is barely but consistently detectable, and 1, which is really quite robust. The effect size for the stimulants in research is pretty close to 1, 0.95. And in research, again, the dose is usually not fine-tuned to the individual. In those dose optimization studies, when the stimulants are fine-tuned, they come in at 1.7 or above. In other words, what you should expect from the stimulant medications is nothing short of wow, life-changing, better than any other treatments in all of medicine. The response rates for methylphenidate and amphetamine are about the same. About 70 to 75% get a good, robust response to whichever one the doctor's feeling luck with that day. When you try both methylphenidate and amphetamine, you get about an 80 to 85% robust response rate. Now, that means that if you don't get a good response with whichever medication you try, don't give up. Try the other medication. But it also means that 15% of people, that's 1 in every 7, so it's common, will try both amphetamine and methylphenidate and not get benefit. There's very little in the literature or in the standard of care to tell you what to do next. The side effect profiles are pretty much the same. One is not any more tolerable than another. So these are the facts in large groups. But in treatment, in clinical practice, we see individuals. And individuals virtually always have a very clear preference for one agent over the other. Nothing predicts it in advance, and as far as anybody can tell, it doesn't run in families. So just because one kid does well on methylphenidate doesn't mean that a sibling or a parent is going to be any more likely to respond to methylphenidate. You just got to try both and see. In my own practice, because the medications are pretty much the only thing I can with assurance tell my patients and their families is going to work, I give a trial on both amphetamine and methylphenidate to every patient to make sure that we've got the very best that's possible. Even if I get a good response with the first molecule we try, for all I know, we might get a great response with the second one. And for medications that somebody's going to take all day, every day for the rest of their lives, it makes sense to take a couple of days up front to make sure that we've got everything that medication has to offer. Concept number 3. While the immediate release formulations are definitely cheaper, it's a false economy. Extended release formulations are to be preferred if they are available, usually financially, for a number of reasons. One is convenience. It's easier to take one pill rather than 3. But you also get more consistent and stable benefits. And if you list all the goals of treatment, they pretty much subsume under the category of stability. What you hope to get out of medication is stability of performance, stability of mood, stability of impulse control, stability of engagement. The other thing is that these extended release formats smooth out the rebound that happens with these medications. The number one reason for children stopping medication is that the immediate release just drops you off at the end. And you get what the slang is Ritalin rebound, just because I think it's alliterative, because it happens with amphetamine products as well. And very commonly at the end, kids will get very weepy, they'll get irritable, they'll have temper tantrums, they'll get sleepy or tired, and this usually happens right as the kid is stepping off the bus, and so that's the only part of the medication that the mom ever sees is the Ritalin rebound. Most people with ADHD have a terrible sense of time. This statistic that's on here actually was the very first thing I wrote on ADHD back when we didn't have computers and cell phones to tell the time. The vast majority of people with ADHD never owned a watch, certainly never wore one. They might have 5 or 6 in the dresser drawer as not so subtle hints at Christmas time that they were commonly late. But time is a meaningless abstraction to people with ADHD that seems so important to neurotypical people, but they've never really gotten the hang of it. So to expect somebody to take medications exactly on time so that there's no rebound is expecting entirely too much. Extended release formats also allow for privacy and confidentiality. It allows a kid to get all the way through the school day without going down to the school nurse to get another dose, and it allows an adult to get all the way through the workday. One thing that I put in there that I always hesitate to mention because it's always heard the wrong way is that on those rare occasions when the ADHD stimulant medications are diverted and abused, 95% of the time it's the immediate release formats, not the extended release. Yet another reason to go with extended release. Nothing is going to predict which molecule or which dose of a medication will get somebody to their optimal level of benefits and no side effects. It has to be determined by trial and error. And nothing at all predicts what that dose is going to be. Many pediatricians especially are trained to do it by weight, so many milligrams per kilogram per day, but there's absolutely no basis for that. It's never actually been shown that there's any correlation at all between weight or indeed any other parameter. There's no correlation between weight, age, gender, scale scores, severity of impairments. Nothing at all predicts the dose or the molecule for that matter. What does determine the dose is how efficiently it's absorbed out of the GI tract. And this is something that changes constantly for children under the age of 16. And indeed, the dose goes down as often as it goes up, to the point where the American Academy of Pediatrics recommends that you readjust the medication once a year. It's usually done in August prior to the beginning of school. Probably the biggest determinant of dose is how efficiently that particular molecule crosses from the blood into the brain, and it's what's called the blood-brain barrier. This is why we never do blood levels of these medications, is that the blood level correlates with nothing at all. The only thing that really matters is how much gets from the blood across the blood-brain barrier into the nervous system. And of course, the rate at which the medications are either metabolized, methylphenidate is metabolized in 6 different ways, or how it's eliminated in the urine. Amphetamine is not metabolized to a meaningful extent in the human body. Virtually all of it is excreted in the urine. So the whole notion of high dose versus low dose is not going to be particularly helpful to us. It makes no sense. And I tend to explain this with what we call the eyeglass analogy. Whatever you can say about a pair of eyeglasses, you can say about the medications for ADHD. I wear glasses because I can't focus my vision the way somebody with ADHD can't focus their attention span and impulse control. You and I cannot exchange glasses. We each need our prescription, the one that's right for us. The notion of a high-dose prescription of glasses versus a low dose is pretty nonsensical. What we want is the right dose for us. And when we have the right dose for us, the right prescription for us as unique individuals, then we see 20/20 largely without side effects. Basic concept number 5 is that there's tremendous variability in what the optimal dose is. The dosage ranges that are approved by the FDA cover only about half of people. Somewhere around 6 to 8% of children, adolescents, and adults get their optimal response without side effects at dosages that are lower than the lowest dosage size made. In other words, if the doc starts off at the very lowest dosage of the particular medication, 6 to 8% of people are already going to be overdosed and see nothing but side effects. As many as 40% of people optimize at doses that are higher than those that are studied and approved by the FDA. So again, we have to look not at high dose or approved dose, but fine-tuning it to the unique individual. Generally, you get the lower dosages by putting medication in a liquid. On the amphetamine side, I use Vyvanse because it is stable in water forever. And you can fine-tune it that way. Or you can use the liquid formulations such as Qualavent XR and that sort of thing to get dosages that are lower than the lowest dose made. The most common reason for this dose determination process to go wrong is that people expect that they should feel something, that they should feel amped up, they should feel stimulated, different in some way. The rule, however, is that the right molecule at the right dose should return a person to normative levels of functioning, not to some artificial state, and without side effects. If a person feels different, the hyperactive people tend to just slow down to a crawl. It's lovingly known as the zombie syndrome, whereas other people get stimulated. It's called the Starbuck syndrome. If you're having changes in personality, you're feeling revved up or slowed down, the dose is too high and you need to go down on the dose. Traditionally, I know in my training, we were trained to give the highest dose that a person would put up with. And now we know that that's at least 2 dosage strengths beyond where the person should be. You have to fine-tune the medication according to target symptom response. I sit down with my patients and say, let's make a list of the things about ADHD which you want to get rid of, that you don't like. There's lots about ADHD that people do like. The cleverness, the problem solving, the creativity, the wacky, zany sense of humor. And the nice thing is all of those things stay when you get rid of the things that the person doesn't like. With adolescents and adults, you can change the dose every day. The stimulant medications are completely effective as soon as they're absorbed. So with the exception of Concerta, at 1 hour, what you see is what you get. All the benefits, all the side effects in 1 hour. There are no late appearing side effects. So with adults, we can change the dose every day if we want to. With children who have limited ability to tell us what the effects of the medication are, we have to slow things down and rely on people who are good observers. If I had to choose one person to give me feedback about how well the medication was working, I would choose the child's teacher. That second grade teacher has been teaching second graders for 20 years. She knows what a second grader should look like. And also she's giving the kid the type of thing that is important for the kid to be good at. It also starts to educate the patient about what the medications can do for them. Remember that people with ADHD have always been ADHD. That is their normal. Usually they have no idea what is possible with the medication. So you need to start the education process about what to look for, what will change, what you'll get out of taking this medication. Also, you need to emphasize that all of these things, the impairments that go along with ADHD, are lifelong impairments, and that taking the medication now prevents these impairments in later life. So I asked the patient, what is it about ADHD that bothers you the most that you want to get rid of? The impairments that respond to medication are things like procrastination, easy distractibility, mind wandering, daydreaming, finding it hard to stick with boring tasks, impatience, impulsivity, and restlessness. Symptoms that don't respond well to medication are disorganization. Again, organization is a skill that you learn. It doesn't come in pill form. Argumentativeness and oppositional behavior. So you tell the patient that we're going to fine-tune to the lowest dose that gives optimal performance. So I say, look at your target symptoms. Each time when we raise the dose, you should see a clear, dramatic improvement in all your target symptoms and no side effects other than a mild, transient loss of appetite. So long as each time when we raise the dose, all you see is things getting better and better, and without side effects, you can keep raising the dose. At some point, though, you're going to raise the dose and say, there weren't any further improvements. Every other time we raise the dose, I can clearly see improvement. This time, this dose and the previous dose seem exactly the same to me. At that point, the previous dose is the very lowest dose that gets 100% of what that medication has to offer. If the person is over the age of 16, that's their dose usually for the rest of their lives. Tolerance is very rare to the benefits of these medications. Tolerance develops very quickly to the side effects of them. You have to accept whatever duration of action happens with that person's optimal dose. The whole notion of trying to increase the dose to make the dose last longer, first of all, it's a very marginal increase in duration, and all it really does is it pushes the person back beyond their sweet spot dose to the point where they start losing benefits and picking up side effects. Remember that even though these medications are marketed as once a day or 24-hour products, that's just a bunch of marketing hooey. With the exception of the skin patch Daytrana, nothing is all day. In fact, you're very lucky to be getting 10 or 11 hours out of any of these extended release products. So we'll have more on that with concept number 10. You need to write everything down. I remember when this finally dawned on me, it was the end of a very long intake. I decided that this person had significantly impairing ADHD, and I was taking that particular moment to give them all of this detailed information about how to fine-tune the medications and stuff like that. The person was smiling, nodding, keeping good eye contact, and they had registered not a single word. So even people who don't have ADHD have trouble remembering how to fine-tune medications. So you need to write everything down. Remember also that there's at least a 50-50 chance that the mother or parent who is accompanying a child to the session also has ADHD. That's just the genetics of it. And failure to recognize that and treat the parent with ADHD turns out to be the leading cause of treatment failure for children with ADHD. So I've spent the last 20 years developing these forms that take people step by step every day, where they can write down what happens for clinicians only. I would be happy to send you all of the forms that I've developed, all the checklists that are in the public domain, everything that I've developed for my practice on a CD-ROM. Just contact me through my email, give me your name and mailing address, and I will put that in the mail to you. There's no reason why you should have to go through 20 years of development. So I'm happy to do this. This is not for patients. I do not want anybody to start adjusting their medication on their own. If you would like your personal practitioner to have them contact me. Basic concept number 10. You need, once you've found that optimal sweet spot dose, you need to ask the patient to lie down after lunch and take a nap on the medication. To prove in a no-risk trial nap, all they have to do is give you 20 or 30 minutes that a second dose of medication is not going to keep them awake. Let's face it, after the age of 14, that's the 9th grade for most people, even an extended release product, and even if it really did last 12 hours, which they never do, even 12 hours is not long enough. A 9th grader has to be up before the crack of dawn, pull themselves together, eat breakfast, make the bus, go to school for 9 or 10 hours, do a sport or work at a job after school, come home, have dinner, and then have 2 to 3 hours worth of homework. And nothing other than Ditrana will get people through that type of 16 to 18 hour day. And the reason that most clinicians don't offer a follow-on dose is that they're afraid it's going to keep them awake, despite their own knowledge that their patients come in and tell them that on the right dose of medication, they slow down, calm down, the chatter in their mind really quiets down. What you're going to find is that 95% of the time, people with ADHD are going to be able to nap on the medication. When that happens, you know they can take a second dose and actually cover all of the time that they need to do it. So again, the medication is more than just for school. It's for being able to be social, get along with your family, do your homework at night, drive a car at night, weekends, holidays, and be safe. And the current recommendation is that you take medication wherever there is impairment from ADHD. Okay, 15% of people do not respond to or tolerate the 2 standard medications. So what do? The second-line medications, clonidine and guanfacine, when they work, have a very robust effect size, about 1.3. Unfortunately, that only happens for about 1 in every 3 people. But when it does, it can be absolutely life-changing. The only other FDA-approved medication for ADHD that has an effect size greater than 1 is methamphetamine. The mere mention of the word gives most people the willies. But it's probably the most effective medication we've ever come up with for the treatment of ADHD. But again, most docs, most pharmacists don't want any part of it. The dosages of methamphetamine that are used in ADHD are extremely low. Your average speed freak starts their abuse career at about 2 grams per dose and then goes up with tolerance. The average dose for a person with ADHD is 10 milligrams, or 1/200th of the abusable dose. Nonetheless, finding physicians who feel comfortable with the use of methamphetamine is somewhat rare. The third-line agent, Strattera, adamoxetine, has an effect size of 0.7 in elementary school-age children. But in high school students and above, and especially in adults, the effects are barely detectable, an effect size of 0.44. And even that barely detectable benefit is found in only about half of people. So it's that's why the American Academy of Child and Adolescent Psychiatry put it in a third line or alternative category. There are other medications in the alternative or off-label group, bupropion, which is Wellbutrin, modafinil, which is Provigil, and the rediscovery of a medication that was used 40 years ago, Parnate, which is an MALI. These are not FDA approved. They are not studied for ADHD, but there is some literature on their efficacy if everything else has failed. So that's a quick overview of how to use the medications. They are the treatment of choice. I've never had a patient say the words, "Gee, I'm glad I waited a couple of extra years before trying medication." It's always the exact opposite. It's what would my life have been like if I had known how well these medications worked. There's a real period of grief about what might have been. These medications don't produce an artificial state. They are a return to normative functioning and no side effects, other than maybe a mild loss of appetite that goes away for most people. So if you are getting side effects, review the dose, try a lower dose, or there are a couple of tricks of the trade to get rid of side effects. But start early and dose consistently wherever there are impairments. So thank you very much for listening, and we'll open it up for questions.
Thank you, Dr. Dodson. There are some interesting questions about some of the new techniques, genetic testing and other testing that assert that they can help determine the right medication for an individual. Have you got any advice as to the efficacy of those new techniques? Some of them suggest that they measure metabolism. Some of them, there are a variety of different techniques for apparently for determining the right medication.
If they do have applicability, it hasn't been proven yet. Right now, personally, I view it as a pseudoscience. What happened was that when they were doing the human genome sequencing 5 or 10 years ago, someone developed a machine that very quickly sequences DNA. So they made it very quick and easy to do. And what they're doing is they're counting the number of gene repeats. They're called alleles. Say there's 7 different repeats of the same gene that makes a particular enzyme, and that enzyme metabolizes the medications. This is where they make their leap of logic for which there's no scientific basis, and they say that somebody who has 1 gene is going to be less able to metabolize a certain product than somebody who has 7 repeats. That's not true. All you have to have is 1 gene that works. The rest of them stay quiet. They're not activated. So the very premise of the genetic testing really has no basis in science at all. So right now, I recommend to my patients that they save their money for something that actually might give them some help.
Okay. Let's see. Tons of questions here. There are a number of questions, some from adults and some from parents, that relate to medication, quote, vacations. So in one case, there's a parent on the webinar whose insurance has run out and they're not able to afford their child's medication for this over the summer, and she's wondering if that's going to be damaging, I guess, medically. There's another adult who is taking his XR long-acting medication only during their work week, and he's also wondering if is that a problem. So can you comment about medication vacations, either long or short?
Sure. The whole thing, and I hate the word medication holidays because it makes it sound entirely too joyous, was originally based on very spurious data that said that these medications could slow the growth of children. Turns out 0 basis for that. Go ahead. There's no basis for stopping the medication so a child will grow. The nice thing about these medications being completely effective in 1 hour is that you don't have to take the medications all day, every day. And indeed, about 40% of my adults use them as needed for a specific task. An attorney who says, I've got to write this legal brief, I'd much rather do it in 2 hours than 2 days, so I'm going to take my medication. For children and anybody basically high school or younger, I recommend take the medication very consistently, more than just for school, because if you look at what the risks of non-treatment are, almost all of the risks occur outside of class. That if you have ADHD and you don't take medication, your risk of developing a substance use disorder quadruples. Your risk of an injury-producing accident that's severe enough to have a hospital record quadruples. Your risk of getting a speeding ticket triples. Your risk of an unplanned out-of-wedlock pregnancy 1,000%, tenfold. Your risk of being involved in the juvenile justice system due to impulsive bad decision-making goes up 700%. And we could go on and on and on. On medication, the risks are the same as the general population. Right now, pretty much all of the risks are associated with not treating ADHD. Virtually none associated with treatment. So when parents worry about sex, drugs, and rock and roll, it all comes from non-treatment. So I strongly say, until you get into college, 7 days a week is the goal.
And that's, I suppose, so that you can best evaluate side effects and effectiveness until a child's able to make their own decisions about those issues, right? I mean, I guess, yeah.
Well,
okay.
Again, it's more than just school.
Right.
You're not going to get pregnant in school. You're not going to have an auto wreck in school. You're not going to be, hopefully, doing drugs in school. You're never safer than you are when you're in a public school. Where the dangers of ADHD are is after school, nights, evening, weekends, holidays. That's where the dangers are.
Okay, great. On the question of the length of time that medication lasts, a couple of questions related to this. From one person, how common is it for children to metabolize extended release ADHD medication and to require a second dose after lunch? This person, both of her children seem to be in that case. And another person who asked whether it makes sense to take first one extended release medication and then when it wears off a second extended release medication as opposed to an extended release and followed by a short acting. So, I mean, I guess the question is how are there risks, or how common is it to have to take more than one medication dose during the day?
Again, that would be ideal, is to be able to truly cover a person's entire day. But insurance doesn't cover that particularly commonly. So they'll cover one extended release dose, and that's it. And so if you want to cover evenings and, driving a car, doing homework, you have to use an immediate release format of that dose. If you are lucky enough to have 2 extended release doses, they are the same dose. You don't need to have a lower dose for the second one. Again, each dose is its own world.
Okay.
Medication gets in, works, leaves, and then you decide what you want the next 8 to 10 hours to be like. There are a couple of wrinkles. The beaded delivery systems. This is Adderall XR, it's Focalin XR, Ritalin LA, Metadate CD, all of these beaded delivery systems. The second bead, when it releases, is determined by how acidic the GI tract is. So people who have heartburn, esophageal reflux disorder, that sort of thing, very commonly all they get is the first bead, and they get 3 or 4 hours out of an Adderall XR, and that's it. So the trick there is to take an acid suppressor like Prilosec or Tagamet or something like that, when you take the ADHD medication, that makes the GI tract much less acidic, and you actually get the second B that you're paying for.
Okay. Interesting. Oh, here's an interesting question from Jeff. He says, how do you know if you should change dosage amount or try a different medication? That's an interesting question. I guess, yeah.
Okay. This is always the question. What's good enough? And again, people with ADHD don't have any idea what's possible. ADHDs are normal. So what we do is, again, we increase the dose as long as you're seeing improvement each time you do. When you increase the dose and don't see further improvement, that previous dose is the best that medication gets. I always do 2 separate trials on the most reliable delivery systems of methylphenidate and amphetamine. The way I look at it is the patient will choose the molecule. My job is to get the very best delivery system that I can with a bunch of skinflint insurance companies. In general, when people have tried both methylphenidate and amphetamine, I ask the following question. I want you to rank your medication, the one you think is best, on a scale of 1 to 10. With 1 being just a really nasty experience, no benefits, just a bunch of side effects, and 10 being the very best response that you can imagine. Rank it somewhere between 1 and 10. Anything 6 or below, I view as a treatment failure, and I'm going to keep looking for a better medication. 7 is acceptable, and usually we hope to get 8, 9, 10. Again, these medications, when they work, are dramatically effective with virtually no side effects. So that's how I and other clinicians will make that decision. Is it exact? No, but it's probably the best we have.
Okay. Similar question. At what point in the trial and error process do you know the medications are simply not going to work? This person's child has tried Concerta and Vyvanse so far, and this week his doctor is starting him on Adderall. She's wondering, how long should this trial and error process go on?
Again, they're delivering only 2 molecules. If you've not gotten a benefit from an amphetamine delivery system, trying another amphetamine delivery system is not going to make any difference. So I do 2 trials. 1 on the most reliable delivery system I have access to for methylphenidate, 1 for the most reliable delivery system of amphetamine. If a person doesn't respond or all they see is side effects, that's when I go to that very last slide about what do you try next. Mm-hmm. When you try that series, ultimately somewhere around 97% of people get an "oh wow, where have you been all my life" level of response. About 3% of people we know have ADHD, and for reasons nobody can explain, just don't get a response to medication. One quick caveat. The number 1 listed drug-drug interaction in the package insert with all of these medications is that they interact with citric acid, which is the most common preservative in the United States, and ascorbic acid, vitamin C. So if you wash down the medication with practically anything that even remotely looks like a fruit juice, all sodas, soft drinks, with the exception of classic Coke, A&W brand root beer, regular and diet Dr. Pepper, or you take it with your multivitamin, the medication isn't going to be absorbed. So you can wash down a tablet of Ritalin or something like that with water, and it'll work just fine. Wash it down with fruit juice, and all you get out of that dose is high-octane poop. It can't be absorbed. So for an hour before or after taking the dose, you need to avoid anything with citric acid and vitamin C. And there will be a list for any of the clinicians that ask for the things that I've developed that lists all the foods that my patients have found have enough citric acid or vitamin C to mess things up. The exception to that, the only oral exception to that is Vyvanse. That you can eat or drink anything you want. With all the others, you have to avoid citric acid and vitamin C.
Okay. That's a great tip. Interesting couple of questions about the long-term efficacy of medication. One person references the MTA study that showed that over the long haul, medication, I believe, was not effective. And a second person references a speaker we had here at Attitude a couple of weeks ago who was a proponent of behavior modification therapy. Nikki summarizes his presentation very well, in which he says that he acknowledged the benefit of medication, but that said that it really only helped children complete their seat work in school, that findings did not show that medication helped on overall achievement scores. Can you speak to those questions about the long-term, if you will, the efficacy of medication on academic achievement or long-term effectiveness in people's lives?
If you have a point of view and you design your study to prove that point of view, you can prove anything at all. That's why I go back to the ACAP guidelines. These are all reviewed, juried studies, and the consistency is 100%. The benefits of behavior management, cognitive behavioral theory, and stuff like that are what we call non-specific benefits. Anybody would do better in a structured, predictable environment than they would in a random, chaotic environment. It has nothing to do with whether the person has ADHD or not. In all of the cognitive behavioral therapies, in the MTA in particular, the MTA came as close to being a fixed study as I've ever seen. What they found was $90,000 worth of behavior management over 9 months, intensive, what they call maximum dose behavior management, added nothing at all to the medication. Nothing at all. The follow-up that the person's referring to, I am amazed that study got published because they included in their analysis people who had stopped taking medication.
Right, that's right, yep.
So, I mean, it's a spurious study. They're saying, yeah, the medication that you took 2 years ago is not working today. That's absolutely true. But to say the medication doesn't work is nonsense. The medications continue to work, and because the stimulants, amphetamine and methylphenidate, have been around 100 years, we have been able to follow people who have taken the medications all day, every day, 50, 60 years, a lifetime, and there is not a single reported problem with long-term treatment. Zip, nada, bupkis. All of the risk is in non-treatment. There's no risk in treatment.
But just to come back to this person's, the assertion that there's no long-term educational benefit, are you aware of that study? Does this mean?
Yeah, and the clinicians out there who have seen kids go from CD students to AB students and continue to do it for their entire career know that that research is crap. Okay. It's nonsense. Yeah, just because somebody got it published doesn't make it true.
Okay.
Look at what you see with your child, with your patients, and go with what reality is.
Very interesting question from Andrew, who says, ADHD rarely exists in isolation. It's always part of a complex with attendant comorbid conditions. What are the drug interactions when you address, for example, anxiety, ODD, and depression, or other conditions, treating those along with treatment for ADHD with stimulant therapy?
Okay. One of the things that makes my life very nice is that methylphenidate and amphetamine don't interact with much of anything. They are very, very simple medications to use, but the only thing that you ever really see is producing side effects is if we've really fine-tuned the stimulant dose and then somebody takes a stimulant on top of that and they get the Starbucks syndrome. But there really aren't any drug-drug interactions in them. When you have comorbidities, coexisting conditions, you have to remember they are two separate conditions. One does not cause the other, and you treat them separately. Most people will start with a non-ADHD diagnosis and try and treat that first. To me, I go with what bothers the patient the most. If their anxiety is what bothers them the most, that's what I address first.
So,
go ahead. The ADHD stimulants play well with others.
Okay. So, for example, some other specific questions, and I think I know your answers. Do you recommend the use of an SSRI to manage anxiety that ADHD medications don't correct? Is there a risk of SSRI toxicity with amphetamine specifically? Is the question.
You will see that as a possibility in some drug compendiums. Nobody has ever actually seen it in real life, but theoretically it could happen. But again, it doesn't. I in 32 years of practice, I've never seen a single case.
Okay.
But the most important thing is to remember that most people with ADHD have a very hard time finding the words to describe what their personal experience is. So the first thing to do is when somebody says, "Doc, I'm anxious," is to make sure they're using the word the same way that you are as a clinician. When somebody says, "Doc, I'm anxious," the next thing I say is, "Can you tell me more about your baseless, apprehensive fear?" Because that's what anxiety is. I have the feeling that something awful is just about to happen. I will tell you that at least 3 times out of 4, when I ask about what's your baseless apprehensive fear, the person will look to me with complete puzzlement, and they say, "Well, I never said I was afraid." And I said, "Well, tell me, forget the label, what are you trying to describe?" And they'll describe, well, I'm constantly going 90 miles an hour. I can't sit and watch a movie. I can't turn my brain and body off to go to sleep at night. I just lie there worrying for hours. And I said, "Oh, what you're describing is the physical experience of hyperarousal and hyperactivity. That's not anxiety." So the first thing you have to do is make sure that you really are dealing with fear and not hyperarousal.
So hyperarousal being a symptom of ADHD as opposed to
yes.
Anxiety, fear, anxiety. Okay, got it. And if it is anxiety, though, you're saying you do treat both conditions, both the ADHD and the
yes.
anxiety, as separate disorders.
Right.
Okay.
And I go right with the American Psychiatric Association standard of care, which is you start with an SSRI, and that's going to be sufficient about 40% of the time, but for 60% of people, you end up having to add in a benzodiazepine.
Okay. This is on the anxiety front. Interesting number of questions about treating children on the autistic spectrum.
I'm going to dodge those.
Okay.
Because I don't have a lot of experience with autism.
Fair enough.
So ask somebody else.
Okay. We'll look for someone on that one. So generics. Do you find the generics of Ritalin or Adderall to be just as good as the brand name medication? Asks Donna.
Okay. The answer is it depends. The ones you really, really, really have to keep an eye on are the generics of Concerta. The FDA has been trying to get those off the market for 2 years because they are not at all, not even close to being generics of Concerta. So the companies are Mallinckrodt and Cudco in the United States. In Canada, it's Teva. These are not Concerta. They're actually failed products. It's the same as Ritalin SR from back in the 60s. If you do get a generic from Watson Pharmaceuticals, which is in the process of being bought by activists, it turns out that is exactly the same as brand name Concerta. They just buy it in bulk and repackage it and make the difference in the face. So make sure that you're getting either activists or Watson generic. With the others, a generic by definition can vary 20% low or 25% high. So that means that there's a variability from pill to pill of 45%. It's not just from batch to batch, it's pill to pill. And again, you just have to try them and see. If you're a person who's very sensitive to dose, generics aren't going to cut it.
Okay.
If you're not sensitive, then yes, save yourself some bucks.
Okay. Interesting question. Will medication improve executive function? To your point about which symptoms respond to medication and which do not.
I'm going to have to label myself as a person who has never thought that the executive function theory was valid.
Okay.
So it's not a concept that I find useful or workable. All
right. I guess what I think we mean by executive function is the ability to plan long term, sort of that, isn't that? So you're saying it's not, to your mind, it's not connected with ADHD, whatever it is. Yeah. Okay. Jackie, will my 22-year-old son need to be on Adderall medication his entire life, or will he outgrow ADD? The background is that he was diagnosed at age 16 when he started driving, got into several accidents, and has not had any driving issues since he's been on his medication.
Yeah. And that's the typical history you hear. ADHD is the way that you are wired neurologically. And on your 18th birthday, you do not get this beautiful package that you open up. Oh, just what I always wanted, a new genetic code, a new nervous system. Nobody outgrows ADHD. It is the way that you are wired. That outgrow ADHD nonsense came from back in the time when the only thing that defined the syndrome was hyperactivity, and sure enough, about age 13 or 14, overt hyperactivity does dim down significantly, and people who were kind of Pollyannish wishful thinkers said, oh good, kids outgrow ADHD. No, nobody outgrows ADHD. The nice thing is that the medications will continue to work without developing tolerance for a lifetime. And most people will benefit from taking the medication pretty much lifelong.
Dr. Dodson, we are out of time, regretfully. We thank you so much. Everyone, Dr. Dodson can be reached at Dr. Dodson at DodsonADHDcenter.com.